So the next is abducent nerve. The anatomy, the course of the nerve is from the pons to the muscle. As you can see in this picture, there is a nucleus in the mid pons. It's closely related to facial nerve. From there it goes and pontomedullary junction, it comes out, and through the clinoid process it enters the cavernous sinus and then comes out to the orbital portion. So coming to the fasciculus, it passes ventrally and leaves the brainstem at the pontomedullary junction, lateral to the pyramidal prominence. It is also closely related to seventh nerve. So sixth nerve and seventh nerve palsy can happen together because of the nucleus and the fasciculus. Lesions in the fasciculus will be Fovili syndrome or inferior medial pontine. Is most frequently caused by vascular disease or tumors involving the dorsal pons. It's characterized by ipsilateral involvement of 5th to 8th cranial nerves. So the pontomedullary junction is where all the cranial nerves are there. It's closely adherent, so that can happen, and central sympathetic fibers, horners, and horizontal gaze palsy can be affected. Then there is something called Millet-Gruber syndrome. Lesions of the fasciculus and the pyramidal tract, ipsilateral 6th nerve and 7th nerve palsy with contralateral hemiplegia. That is Miller-Gruber syndrome. You would have read it in medicine. Basilar part, it leaves the brainstem at the pontomedullary junction. This part comes in contact with important structures such as tip of the petrous bone, passing through or around the inferior petrosal sinus through the Dorellos canal, which is very important, underneath the petroclinoid ligament to enter cavernous sinus. So there are two lesions that can happen. One is raised intracranial pressure. Raised intracranial pressure may be due to posterior fossa tumors or pseudotumor cerebri, or otherwise called as intracranial idiopathic intracranial hypertension. There is herniation of the brainstem. As a result, sixth nerve on both sides are stretched over the petrous tip, leading to bilateral sixth nerve palsy. This is what is called false localizing sign. That is, you might think the course of the sixth nerve is affected, but because it's having a bending course or it has a stretch in the petrous tip, what happens is any increase in pressure can compress the sixth nerve and causes a false localizing sign. Then the last is Gradinoco's syndrome, most frequently caused by mastocytitis, acute petrositis. It results in damage of sixth nerve at the petrous tip. The latter is frequently accompanied by facial weakness, pain, hearing difficulties. I remember it as deafness, diplopia, and discharge. That's how I remember Gradinico, DDD. So that's basically mastocytitis, petrositis causes this. Intracavernous part, it lies in the substance of the cavernous sinus. It in close association with the internal carotid artery and the sympathetic plexus. Occasionally, intracavernous sixth nerve palsy is accompanied by postganglionic Horner syndrome or Parkinson syndrome. So postganglionic Horner syndrome with intracavernous sixth nerve palsy is called Parkinson syndrome. Remember that, due to damage to the paracarotid sympathetic plexus. It's all in close proximity towards Horner syndrome. You would have seen in my orbit class that the sixth nerve and the internal carotid artery were very close together. And the intra-orbital part, it enters the orbit through the superior orbital fissure and supplies the lateral rectus. So the causes of sixth nerve palsy could be vascular causes such as diabetes, trauma, tumor, petrositis, mastocytitis, all these things. Diabetes, I have seen patients having diabetes and sixth nerve palsy. So clinical features of sixth nerve palsy would be horizontal uncrossed diplopia. Diplopia uncrossed, okay, whenever there is esotropia, there is uncrossed diplopia. Exotropia, crossed diplopia. In the X itself has X, so it's crossed, remember that way. Diplopia is maximum on the lateral gaze of the affected side, because that is the direction of the muscle action. Let's say I have sixth nerve palsy on the right side. What happens is I cannot move my right eye to the right side because the lateral rectus is palsied. The medial deviation of the eyeball, esotropia will be there, obviously, because my right eye, I cannot, my lateral rectus action is less, so my medial rectus pulls the eye to this side. Face turn to the same side for a compensatory posture. That's very logical. If I cannot see this side, because if I cannot move my eye this side, obviously I will turn my turn my eye and the head on that side and see the thing. So this patient, acute left sixth nerve palsy, and because of which the patient has esotropia in primary position. When the patient is trying to abduct on the left eye, what happens is, as you can see, the patient cannot abduct, whereas the right eye will adduct.